Hi, good afternoon, good morning, good evening, everyone. Welcome back to another session. I am beyond excited to introduce the RGH Internal Medicine Residency Program as one of the presenting program today. Um, this is where I work, and I've worked with a whole bunch of residents from their program since September of this year. And I will say that I'm like privileged to learn from them and teach them. They're like a really great bunch. And you'll see today of how well they present and how well, like what type of cases we see at our program here. I'm going to start off with the residents first to go in order and just introduce themselves and tell us something fun outside of medicine.
Hi guys, I'm Dua. I'm one of the internal medicine interns at the RGH, and I'm originally from Pakistan. Pretty boring at baseline, so nothing too much fun about me. But outside medicine, I think I'd say that I love animals a lot. Like I'm crazy about them. So yeah, that's about it.
Awesome. And then Tulu, do you want to go next?
Yes. Hello, everyone. My name is Toluwani. I'm from Nigeria. I'm one of the interns at Rochester General Hospital. Outside medicine, I love to travel and also to bake.
That's awesome. And just fun fact, I'll be working with Tulu in about 48 hours. So I'm very excited about that. Um, and then I think Basant, no, not Basant. Lara, you're next.
Yes. Hey everyone, I'm Laura. My last name is pretty hard to be pronounced in English, but in Brazil, if there's any Brazilians here, it's Almeidinha, and it's truly my last name. But this joke just makes sense in English, in Portuguese, not in English. I'm originally from warm and beautiful Brazil, and I'm emphasizing warm because now here it's like frozen in Rochester, and I'm a PGY2 at RGH, and I'm really happy to be here. Fun fact about me. Well, I might quote Dua that I am a dog lover. Actually, from the animals, I'm gonna pick dog. I have a golden retriever and a mixed breed, and I would say that they are more used to the US than I am.
Awesome. And another fun fact is Lara and I have been working with each other for the last week and another week next week. So yeah, and last not but least, Basant.
Hi everyone, I'm Basant. I'm a BGY2 at RGH. I'm originally from Egypt, also very warm. And something I like to do outside medicine is I like to take walks around in the parks around here when the weather permits and trying different ice cream flavors.
I love that last answer. Thanks, Basant. And then Anas, do you want to introduce yourself?
Yes. Hi, everyone. My name is Anas Hashem. I'm a fourth-year chief medical resident at Rochester General Hospital. Originally from Syria, I was born and raised in the United Arab Emirates, did my medical school there. Something fun about me, I enjoy biking in my free time to the extent that I broke my forearm.
Oh, awesome. Thanks, Anas. And then let's start off with our discussants today. Yaz, do you want to go first?
Of course. Hello, everyone. I am Jess from Mexico. I am an IMG, and this cycle I'm applying to internal medicine. And my fun fact about me, I used to have 84 plants, but a couple have died. But yeah, this is basically my pride and joy.
Awesome. And another fun fact, when both Yaz and Jazz are on the VMR, it's always a confusion of who is Robbie or Reza talking about. All right. And then last, no, not last, but Anmol next.
Hello, everyone. My name is Anmol Preet, and I am an international medical graduate from Punjab in India, and I'm also applying this math cycle. Fun fact that outside of medicine, I think it's a typical one. I love to sing and I love to dance. And in dance, I love especially Bhangra. That's a Punjabi folk dance. Yeah, that's about me.
Awesome, Anmol. And then last but not least, AMK.
Hey everyone, so happy to be here and discussing. I know that based on the cases Jazz has brought, we're in for an amazing case today. And I was telling Yaz and Mol that like I'm feeling a little under the weather today, and so I'm just so excited to let them shine and get to listen to all their brilliance because I've heard them discuss before, and it's going to be great. A fun fact about me is that I like to run outside of the hospital, even sometimes when I shouldn't, which I did this morning when I was sick, which is probably why I'm in the state that I'm in, but I'd already signed up for a 5K. So there we go. And I currently work at UNC, so happy to discuss today.
Awesome. What a great lineup. Let's get started. So, Valet, if you want to share your screen, and then I'm going to stay quiet for the rest of the session.
Can I go ahead? So I'm gonna go ahead with my first aliquot, and I'll present the problem presentation first. So it is a case of a 39-year-old male who presented to the clinic with unintentional weight loss of approximately 50 pounds and fatigue for more than a year. Going to the history of presentation, so this patient was actually seen a couple of times by his PCP during this period due to elevated LFTs of unknown etiology. He also noted having some lumps in his neck and groin in the past few months, but did not follow up on any blood work or on any imaging. The patient denied any chills, fevers, night sweats, trouble swallowing, or voice changes. He also denied any cough, shortness of breath, chest pain, palpitations, orthopnea, paroxysmal nocturnal dyspnea. He has no bruises, no history of bleeding easily or any myalgias. He denied any blood in the stool, constipation, and melena. History was also negative for polydipsia, polyphagia, and polyuria. The rest of the review of system was also completely negative. So this is the end of my first aliquot.
Friend Alma, would you like to tackle first the first aliquot, or?
Okay, I can share some of my thoughts. I think first of all, if we talk about the age of the patient, it's a relatively young or middle-aged patient presenting with the unintentional weight loss and fatigue over a year. This kind of paints a picture of an inflammatory picture for me, some chronic inflammation going on inside the body, which is presenting in the patient in this way. So what could that be? We cannot say that right now. The differential is very broad. It could be autoimmune etiology, it could be malignancy, or it could be chronic subacute hidden infection that could cause that. And since the patient was seen in the clinic, so I would say maybe the patient is vitally stable, that he's not presenting an emergency. And this something chronically building up, which is being probably compensated by the body. So the body is compensating to whatever is happening. And that's what I'm thinking right now. The differential is very broad, if I may say. And the only another thing that's positive, I think that's elevated LFTs, which we don't know what the cause for that is. And I think it would be interesting to see what is the value of AST, ALT. I think they must be around below 1,000. That's what I believe. The chronic elevations, and but I can't really say what the chronically elevated LFTs could mean. Yeah, that's what I'm thinking right now. What do you think? Yes.
Gosh, Alma, I really like how you framed this as a chronic issue. And for me, weight loss, I'm right there with you. I normally associate it with this endogenous factors like a malignancy, endocrinopathies. Again, this patient is young. And I'm not saying that because I'm in my 30s, but this patient is relatively young. So I would also want to ask about gastrointestinal issues, obviously putting into our list Crohn's, ulcerative colitis, celiac disease. We can also think about, as you mentioned, ID, some chronic diseases like tuberculosis, or even look for something that could be a little bit more chronic, although that would be like the first one, and also reviewing exposures. On the other side, when we talk about LFTs, elevated LFTs, and I love the point that you made of this being a chronic elevation, chronic progressive elevation. Something that I normally look at LFTs is like AST ALT ratio, try to see if it's less than 1 or higher than 1, because it can tell us, kind of point us if this is a AST ALT ratio less than 1. We can think about something viral, or fatty liver disease, or even extrahepatic causes of cholestasis. If it's higher than 1, we can think about, well, is this patient, does this patient use alcohol? Or if this patient has any risk factors for developing cirrhosis. Although he's young again, I would definitely like, my next steps would be asking occupation, exposures, risk factors, family history, looking for liver disease, because last Sunday we learned with Dr. Attending Mark about having a certain genetical component can predispose our patient to the develop liver disease. But I think I already talked too much. So yeah, Dr. MK, something that we should also think about?
Yeah, so great discussion. I'm just going to summarize some of the really key points that I think you all made to start out with. So what I heard you say, Yaz, and Imnal, is that first of all, this degree of weight loss, it seems like it is a more like concerning or malignant cause because of the degree of it and some of the kind of company the weight loss keeps. But we also have to kind of temper that with the fact that this has been going on for a very long time, a year time course, and the patient was able to present to clinic. So something that is caught a very serious cause, but also has a slower time course. And then, so you're kind of mentioned, and then we're going to interpret that to kind of with that an inflammatory kind of component of that. And so you took a step back and said, who is this patient? What past medical history do they have? What kind of exposures do they have? Family history that could kind of help inform what could cause this. And then you also said, like, what could kind of cause a really serious illness, but in a slower, more indolent time course. So you were thinking about the inflammatory causes, like autoimmune diseases, and the overlap with endocrinopathies that could overlap with autoimmune diseases. And then you were thinking about like more indolent infections. I heard TB mentioned, and also thinking about like what infections could have a slow time course, and then thinking about some sort of inflammatory or malignancy, but that could have like a slower time course, because we have to think about assuming that everything's related about the time course. And then also thinking about like the genetic background. This patient is younger, but is there kind of anything in there that could predispose? And then kind of trying to say, like, how could the other company it's keeping, the elevated LFTs and the lumps, contribute or maybe give us clues, but it's a little hard without knowing kind of the degree of the LFT elevations. And then also if it's cholestatic or hepatocellular, exactly kind of how that might fit in, but acknowledging that it could go together. And then I just want to commend the Rochester team for and Dua for such a good review of systems, because some of the things we were thinking about, like diabetes, the dysuria, like some of the malignancies, or inflammatory conditions, thinking about like the bleeding and bruising history and everything like that. So I'm definitely kind of thinking about it, and curious and excited to get more information.
So now I'll move on to my second quad. Regarding the past medical history, it was significant for type 2 diabetes mellitus, GERD, bilateral vitreous hemorrhage, bilateral nephrolithiasis, elevated LFTs of unknown etiology. Regarding meds, the patient was taking metformin 500 BID, pantoprazole 40 mg once daily. He denied any herbal or over-the-counter medications. His family history was relevant for pancreatic cancer, sickle cell trait, and diabetes on his mother. Father's history is unknown. He does have 3 siblings, but they are all healthy. Regarding the social history, he has been in and out of incarceration a couple of times and lives with his wife and has 6 children, and all of the children are healthy. He smokes 1 to 2 cigars a day, drinks alcohol but occasionally, and denies any recreational drug use. And he does not wear CPAP at home. He does not use oxygen at home. And the patient denied any allergies.
So should I tackle this first, Emmeline? Okay, perfect. Well, now a really nice and rich past medical history. This patient, for starters, has type 2 diabetes mellitus that can predispose our patient to a progressive renal damage. And I'm saying that Dr. Snyder is here, so now I'm a little bit more nervous about saying something about the kidneys and being completely wrong, but I also see that this patient also has treatment with metformin. I will be wondering if his glycemic control was good. This patient also has a family history of sickle cell trait. I'm wondering if this could predispose him to also have it. And this is a small knowledge gap for me, but if my memory serves well, in sickle cell trait, certain factors as infection or inflammation can trigger hemolysis in patients with sickle cell trait. So that would be something I will keep in mind. Another thing is that he had been exposed to being incarcerated. So that also predisposes him for hepatitis. So a hepatitis panel and a viral panel in general would be definitely on my workup, as well as a TB one. So what do you think, Amma?
Yes, great points and an amazing aliquot. But if I see if what the red points in this aliquot will be, then type 2 diabetes mellitus in a very relatively young patient, I think, and the presence of GERD. I saw a great comment in the chat about the presence of MASLD. I think knowing the BMI of the patient would definitely be great if why the patient is having GERD-like symptoms and why the type 2 diabetes mellitus is there. Talking about the bilateral nephrolithiasis, maybe what the kidney stones are made up of. It is very interesting why the patient is having the kidney stones. If it is decreased water intake, or maybe increased calcium, increased uric acid, what could be the cause for that? So that is interesting too. And again, the elevated LFTs of unknown origin are definitely the tricky thing to tackle. That why are they chronically elevated? Because any kind of acute viral hepatitis is dangerous. So yeah, so that was what I'm thinking about it. And the family history is positive for cancer. So yeah, and there's significant cigarette use. There are multiple risk factors present. So yeah, definitely takes the case in a different direction, and I'm excited to see what comes next. Yeah, that's what I want to say.
Yeah, great discussion. I think a few kind of thoughts I had, just like building off the thoughts that you had. So whenever someone has a diagnosis of diabetes, thinking about when it was diagnosed, how it was diagnosed, what their control has been, what their access to meds are, and making sure that it's the right diagnosis, because I think sometimes since we see type 2 so much more, Occasionally, if someone presents late or has like some like the late onset autoimmune, they can be misdiagnosed. So making sure that like trying to go back and making sure that type 2 diabetes is the correct diagnosis. And then also saying like, how has the control been? Because that can inform kind of a lot of the other kind of metabolic downstream consequences from diabetes. A lot of it is very contingent on the kind of control and access to medications. And if maybe it wasn't type 1 diabetes, that could inform kind of other autoimmune possibilities. So I always think it's good to have, as much as possible, have that history. The other kind of query I had that may or might not be significant is having bilateral vitreous hemorrhages is not something that occurs commonly. And because it's bilateral, say that's a little atypical. Certainly, like there's a few different risk factors, poorly controlled diabetes, sickle cell trait could perhaps, I think sickle cell disease can be associated, but also saying like, is there some underlying coagulopathy or is there anything else, or a trauma like, you know, that could, and that could be totally non-relevant to this case, but it is something that I think I would want to know a little bit more information on, as well as we've already talked about getting the information on the LFTs, and then just kind of echoing what you said about kind of the what Yas says about thinking about with being incarcerated, what kind of risk factors that can have for different diseases, including hepatitis, TB, asking if there's been any past TB testing as well. So excited to hear more.
Okay, so now to the third aliquot for his vitals. His temperature was 37.1 degrees. Heart rate was 98 beats per minute. Blood pressure was 125/72. Respiratory rate was 20, and saturation was 100% in room air. For physical exam, for general, he was alert and oriented to person, place, and time, and he wasn't in any acute distress. His oropharynx was clear and moist, and conjunctiva was normal. For cardiovascular system, he had normal rate and regular rhythm. Examination revealed no gallops and no friction rub. No murmurs were heard, and he exhibits no edema. For pulmonary, effort was normal and breath sounds was normal. He didn't have any respiratory distress, no wheezing, no rales, and on palpation, there was no tenderness. For abdominal exam, his bowel sounds was normal, no palpable lymphadenopathy, spleen palpable on deep palpation in the left upper quadrant. Hepatomegaly was felt and border 4 to 6 centimeters below his ribs, and he had bilateral inguinal lymphadenopathy. For musculoskeletal system, he had normal range of motion. For skin, he was not diaphoretic and he had no rashes. For neuro exam, everything was normal. There was no deficit and had normal gait. For psychiatry, he had intact mood, affect, and appropriate behaviors. Going on to his labs, for CBC, his WBC count was 2.9, RBC 2.26, hemoglobin 6.9, hematocrit 21, MCV 94, RDW 14.1, and platelet was 76. His differentials was significant for lymphopenia with a leukocyte count of 15%, and the rest of the differential was normal. For CMP, he had low sodium at 134, BUN creatinine 27/2.1 with baseline BUN and creatinine of 18/1.1. His glucose was 60, calcium was 9.2, total bilirubin was 2.7, AST 41, ALT 41, alkaline phosphatase 693, and GGT 267. The rest of his CMP was normal. The rest of his chemistry lab was significant for a negative ANA, ferritin of 102, F-actin antibody IgG of less than 20, HIV 1 and 2, which was non-reactive, hepatitis B and C panel was negative, and alpha-1 antitrypsin was 191, which is elevated, transglutaminase antibody 10.3, which was elevated, mitochondrial M2 antibody was less than 20, which was negative, and an elevated IgA of 1,306. This is the end of the third aliquot.
Before, Yazin and Emil, before we discuss, it might be a good time to pause and think about a problem representation.
I completely agree. I see that it's so rich, the article. I really like the way that this case is being presented. So, Emma, would you like to go first in a proper representation, or would you like me to do it?
Whatever way, yeah.
Okay, friend. Why don't you try?
Maybe in the chat as well if y'all want to
Oh, yeah,
be
definitely,
thinking about and adding them.
Because we started with a 39-year-old man with a chronic inflammatory, like weight loss disease and elevated LFT. So we started knowing that this patient had inflammation and had hepatocellular damage with a past medical history of type 2 diabetes mellitus, and also a family history of pancreatic cancer, sickle cell trait, and DM and his mother. Also has a past medical history of incarceration. He has relatively normal physical examination, but here the spleen, we have splenomegaly, hepatomegaly, and we cannot forget the lymphadenopathy in his inguinal area. We have low white blood cell, low red blood cells, and low platelets. So we're talking about pancytopenia now. What would you add, Anmol? I'm definitely wondering if, oh, and the alpha antitrypsin is elevated. So
Yeah, I think that's perfect. But definitely there is pancytopenia with infiltration in the liver and spleen. Whatever is there, it's infiltrating both of there. And we also have inguinal lymphadenopathy. Inguinal lymphadenopathy, when I think about that, I mostly think about parasitic infections. But in this case, with the chronic scene going on, and I believe the physical exam, we mainly have three positive findings, that is splenomegaly, hepatomegaly, and inguinal lymphadenopathy. And since the patient presented in clinic, the vitals are definitely normal. And with the pancytopenia, now we have to think if the bone marrow is involved. That is one question here, if we can consider that. And we were talking about AST and ALT. They are, I think normal values is 40, so they're 41. I won't say they're much elevated right now, but we do see elevation of ALP, which makes me think if it's a cholestatic picture with the elevation of bilirubin as well. That's what I'm thinking. And the alpha-1 antitrypsin, I think that I can make what alpha-1 antitrypsin would do in this case. Maybe it is related to some lungs and liver common causes. So that's what I'm thinking. Of what do you think? I think I'll just take some time to think over it. What do you think?
Yeah, no, I agree. It definitely sounds like here, I think we might be thinking about, is there involvement of the reticuloendothelial system? We have what sounds like hepatosplenomegaly. We have lymphadenopathy. I am curious because I mentioned lumps both around the groin and in the neck. So I'd be curious if there was also cervical lymphadenopathy, because that could change our differential. But I think at least there's some degree of lymphadenopathy. There's hepatosplenomegaly. And then on exam, we see this pancytopenia, which I'm curious about, kind of as you discussed with pancytopenia, we think of our kind of big topics. So we think about, is it a bone marrow problem? Is it a destruction problem? Or is it a sequestration problem? And sometimes it's more than one of these. So with a splenomegaly, could there be some degree of sequestration? I certainly think it's possible. But before we invoke that, we need to look for like the bone marrow production, think about getting a reticulocyte count, which is the injection fraction of the bone marrow. Think about sending a smear because we also have pancytopenia. Is there some sort of either malignancy or like chronic autoimmune disease, that we might see abnormalities. Think about like looking for kind of the low-hanging fruit, all the nutritional causes, B12, folic acid, copper, zinc, especially if there is perhaps some degree of like malabsorption, or something at play. And then, think about like, do we need to get some sort of bone marrow biopsy? But I think we also have to consider is, besides bone marrow, is it a building block problem, or is there something taking over the bone marrow, or is there something destroying the bone marrow? So thinking about kind of with our category and we're thinking about perhaps reticuloendothelial system. So is there either some sort of granulomatous process? Is there some sort of autoimmune process? Or is there something that's like taking over the bone marrow? And so we very much might need a bone marrow biopsy. We'll have to kind of see how this goes on. But then if we think about here, and you think about the categories of liver injury, it looks like it is cholestatic, which goes kind of with our kind of thought about, is there some sort of infiltrative process here? I would say the antitrypsin, I think it was obtained just thinking about, things that can affect the liver. The fact that it's elevated is just probably an inflammatory response. Many of these kind of things can be elevated with nonspecific inflammation. So unless there's something I don't know about, that's how I would interpret it. And then this transglutaminase antibody is interesting. I was wondering if it was like a tissue transglutaminase. I'm thinking about celiac disease. And so I would have to but I didn't see the tissue transglutaminase. And certainly celiac disease can be associated with elevated LFTs. Usually it's like a minor elevation in AST and ALT. And so it's always important to think about. And it can be associated with like increased lymphomas, but I don't really feel like for here it necessarily, like, before going to that, I'd want to like make sure that I had looked into other causes as well. So I definitely want more information on that. And then I'm a little puzzled by the elevated IgA. I don't know if anyone else has any thoughts on that. Certainly if you're thinking about celiac, you should always check an IgA, because IgA deficiency is more common, and usually the celiac antibody is like an IgA antibody, so you want to make sure. But the fact that the IgA is elevated, I think could be kind of a number of different things, from like some sort of autoimmune to inflammatory. So that's interesting, but I don't know if anyone else has any other thoughts on it.
I do. Actually, I wanted to like bring to the table the possibility of thinking, look, when I was reading for like that this patient also has an IgA elevated, we have IgA, pancytopenia, and nephrolithiasis. So I'm wondering if, and the presence of hepatosplenomegaly, that if this could be predisposing us to multiple myeloma or lymphoproliferative disorders like Castleman's, because I remember that in one VMR in the chat, they mentioned that people that have lymphadenopathy, hepatosplenomegaly, high IgA, and the systemic symptoms with elevated ALP can make us think of this kind of disorders. But I think it's rare, although we could keep it in the table. Other inflammatory diseases, organomotor diseases like sarcoidosis, could also present with this IgA elevated. If I would love to be corrected in the chat if anybody has any other thought. And another thing that I would definitely like to ask is the level of ferritin in this patient. Maybe I'm being a little bit biased, because we do have, again, pancytopenia, hepatosplenomegaly, elevated LFTs. If there would be like high ferritin, I would be looking for HLH. Although, I mean, those are like more obscure the differential diagnosis in my book. But, oh, we do have ferritin. Sorry, I didn't see it. So yeah, those are like infiltrative or lymphoproliferative disorders are definitely in my DDX.
So there is so much data here that I think it's hard to discuss everything in like one go. So kind of looking at that ferritin, what do you think of that ferritin in someone who like seems very inflamed? What might that like give you a clue for?
I will say like I would have expected to have like I think that my iron deposit is low, like that I don't have. This has been for so long that we have this low availability of iron, but I'm really wondering, Anmo, what does it make for you?
I think it's the normal value of ferritin, or what is it? It's the normal value, right?
Yeah, so it's normal
Yeah, I was expecting
on the
maybe it's an
border.
acute phase reactant, so it should be high, on the higher side in this inflammatory picture. But it's normal, definitely. Uh, um, I wouldn't say it's a hypoferritinemia, but in the case if we suspect inflammation, then we may think it that way. But what things are crossing your mind?
My mind, it's way lower than I would have thought it would be in someone who has what seems like inflammatory. So it definitely makes me wonder about like 100 is generally like the cutoff. Some people say 200 for like if you're inflamed, kind of what you expect like the ferritin to be, even if you're iron deficient. So I'm definitely wondering about an iron deficiency here. So I'd probably get some more iron studies to better assess that. And also kind of thinking about, again, I think we have a question about malabsorption. So also getting kind of all the other kind of low hanging fruit for pancytopenia here to see. Um, what about, it seems like it's a glucose 60, so it's low. What are you thinking about like with the low glucose and then the sodium of like 134? What are some of the things crossing your mind with that?
I think sodium seems to be normal. It's 134. I think normal value is 135 or something.
Yeah.
Yeah, and if it's um maybe if you're thinking about some endocrinopathy in this case, but normal glucose level of okay, so maybe if you want to send the test for that as well, I think it's the right time to send the test too, because when the glucose level normalizes, I think but yeah, I don't know, maybe if glucose can be low in sepsis as well, but there is no picture of sepsis, so maybe some endocrinopathy. What do you say? And I think it's or maybe over treatment of type 2 diabetes. Maybe the patient is taking insulin or something like that. So
I really like that thought, Emil. Another thing that I would like to know what you think about is asking for anti-smooth muscle antibodies, or like look a little bit more, because now that you mentioned about the transglutaminase antibody being high and the possibility of this being a malabsorption disorder, trying to put this in a Venn diagram of what can cause malabsorption disorders could be like celiac disease or other intestinal like intestinal bowel disease, and liver issues would be primary sclerosis cholangitis, which affects middle-aged men primarily. So, and this patient has high LFTs, high ALP, hepatosplenomegaly, and again, high IgA and elevated transglutaminase could indicate this association to autoimmune diseases like intestinal autoimmune diseases. So I would like to know, what do you think?
Yeah. I think just for time wise, we should probably move on. I think just something we should note is this elevated creatinine. We definitely don't want to forget that and like work it up and say like, is this more dehydration as well? And I was definitely kind of wondering with the low glucose, is this just like really poor, like either your absorption, is this liver, because liver stores the glycogen stores, is this like an inflammatory response. So just like thinking about this, it seems less likely to be adrenal insufficiency, even though it's something I never want to forget, just because the normal blood pressure, I don't see any like EOs noted or anything like that. So let's get some more information and then we can go from there.
All right. I must say that I'm loving to hear this discussion. So moving forward with some more data. The electrophoresis showed a total protein of 7.7. Albumin was low at 2.8. SPEP was normal and paraprotein was not detected. Kappa to lambda free light chain ratio was 1.5. 125 dihydroxyvitamin D was 89, which is elevated. PTH-related peptide was normal. PTH was low, 6.3. Vitamin D 25-hydroxy was low at 10. Ultrasound of the abdomen showed the hepatosplenomegaly and the nephrolithiasis. EKG had no acute findings. The chest X-ray showed a small right pleural effusion with adjacent airspace disease. CT chest showed a mediastinal, hilar, and bilateral axillary lymph node enlargement, bilateral lower lobe airspace consolidation, small to moderate right-sided pleural effusion, bilateral peribronchial thickening, innumerable miliary nodules. CT abdomen showed a massive hepatosplenomegaly, a 7 mm calculus in the right proximal ureter resulting in right-sided hydronephrosis. Additional bilateral non-obstructing renal calculi was also noted. So this is the end of the fourth aliquot, and in the next aliquot, we'll review the final diagnosis.
Okay, so I'll go first in this one. That's an amazing case, first of all. Great job with that. But I think the thing that strikes, first I'll talk about the right pleural effusion if I want to talk about that. We were, since the beginning, talking about some problem with the liver enzymes, the liver. So maybe one of the differentials for that could be hepatic hydrothorax. That's what I'm thinking. And isolated right-sided pleural effusion could be, I believe, could be transudative as well from the liver, from the heart. And if then we talk about the other things, that the miliary nodules, I think, which we saw in the CT, it could represent multiple things, and one of them could be TB. It could be miliary TB, and but I think some other diagnosis can also present like that. And the low PTH, I think we saw the low PTH. So with that, I guess we do expect, I think, the calcium and the phosphate levels, the ranged calcium and phosphate levels. I'm not sure how to just, what was the calcium level? It was 9.1, okay. So yeah, the PTH is low, and vitamin PTH, okay. I think that's what I'm thinking from the 1 or 2, 3 findings. The other things which we already knew about the hepatosplenomegaly and the bilateral nephrolithiasis. I'm still at the same things. If it's a chronic infection or if it's malignancy, I think I'm still at the similar things. What do you think?
Well, I'm trying to like change my problem, like add to the problem presentation. So in this patient, he has also bilateral nephrolithiasis. I remember listening pleural effusion, unless I wrote it wrong. He also has mediastinal and bilateral hilar lymphadenopathy and miliary nodules. So what I'm thinking is this inflammatory and infiltrative disease. So something that comes to my mind will be sarcoidosis, although I really don't know where to piece together the vitreous hemorrhages and the presence of nephrolithiasis. Oh, I see that nephrolithiasis can be seen with sarcoid. So that's another, that mystery was resolved for me. But something that I would really like is maybe this patient to get a hemoglobin electrophoresis, because if he also has a sickle cell trait, he might he might be predisposed to these vitreous hemorrhages, right? And other things that come into my mind when I see all of these findings in the CT is obviously malignancy, like the chronic myeloleukemia. And again, Castleman is also there because we have all of this LFTs, elevated IgA, miliary nodules. Another infiltrative disorder that could be like on the expanded area would be amyloidosis. And again, I leave the last for the best in my case because of ID love. Like for me would be tuberculosis because of his past incarceration. It can be a risk factor. And something that I would definitely like to bring is the disseminated histoplasmosis, because I remember that it was even Jazz who taught us that fungal infection like histoplasmosis and disseminated histoplasmosis can present with miliary nodules, can present with splenomegaly, lymphadenopathy, elevated LFTs, and this patient is in Rochester, New York, which is an endemic area for histoplasmosis phaneron. So I would also keep that in mind. And that would be like my DDX so far. What do you think, MK? Did I miss something?
No, I think it's a great differential. So I think we have a few clues to what's going on here. One of them is you might have remembered, sounds like the 125 vitamin D level was elevated. So do y'all think of what conditions, if I heard that right, what conditions normally elevate the 125 vitamin D?
I think something maybe affecting the kidneys can.
Yeah. So if you remember so there's 25 vitamin D and it is converted in the kidneys to 125 vitamin D by the 1-alpha hydroxylase antibody. But a lot of times, like lymphoma and granulomatous diseases are associated with elevated 125 vitamin D, which I think goes with our prior hypothesis about like we feel like it was probably infiltrative involving the reticuloendothelial system and everything like that. So I think that kind of goes with it. And so I think that that's a really good clue like for us. And then I think where I'm struggling right now is to figure out kind of as Emil and Yas mentioned, our concern for TB sounds like there's like kind of a miliary pattern. So thinking about TB and then like the things that can imitate it, like fungal, but then also saying like some of the other things that can cause a miliary are sometimes some of the other cancers, but then also saying like, could this be some sort of lymphoma too? Or like, could this be some sort of weird presentation of sarcoid, which I would have lower on my differential, quite honestly, at this time, but still something that like kind of if everything else had been ruled out, I wouldn't expect quite this hectic and just like severe representation, but definitely just something still I'm thinking about. So like I'm a little bit stumped and I think I'm having trouble. I think we're kind of like, well, we feel like we have a good idea, like it's some sort of granulomatous process. I feel like I'm kind of having trouble saying exactly what it is, but I think the first thing that I do in this case is evaluate for TB, put on airborne precautions. There are certainly risk factors, and then think about getting a biopsy and thinking about like, you know, like as kind of a secondary like lymphoma and everything. So that's kind of where I am. Do y'all have any other thoughts? But I certainly, you know, think that there could be kind of several different things going on here.
Yeah, I think whenever, if aside from this case, I talk about lymphadenopathy, whenever we see such systemic lymphadenopathy, two of the important tests to send are HIV and syphilis. And whenever we see such vast lymph node enlargement, then we also look for a site to biopsy so that we can make out some diagnosis with that. And maybe if how the case is going, maybe we can see a granulomatous evidence in the lymph node biopsy. But what test, if we have to talk about what test to send next, then I think definitely looking for a site for lymph node biopsy would be great. And maybe evaluating that vitamin D and calcium, all of that, knowing the phosphate levels, if they are in normal ranges. What test would you send next?
So I think I would I would do the TB evaluation, and then, look at getting a lymph node biopsy, and then, but also kind of have sarcoid but that's a diagnosis of exclusion. So we're going to evaluate kind of for TB, all the fungal causes, lymphoma and everything first would be my order of operation. And I do believe in HIV, was checked in negative. And so just so I'm not that's definitely something we don't want to forget, but I believe that was mentioned earlier in the case.
Yeah,
Yeah, and that is, sorry, go ahead, yes?
No, I would definitely want to know, like, if a bone marrow biopsy would be a good idea in this case when our patient has pancytopenia. And if we're thinking sarco, also think about like AC levels, although I remember it was not like specific or sensitive. I don't remember very well. And also like a bronchoscopy for or like a biopsy to see the tissue in the lungs. What do you think?
I think a bronchoscopy was sending, hopefully if you had TB PCR and then the other fungal things like histo, blasto, that you could see in that part of the country. And then you could also send cytology and flow for lymphoma at that time. So I think I'd be talking to interventional pulm, and one way or another, we need some sort of tissue sample and fluid sample. So, to get to our diagnosis. ACE levels are definitely they can be helpful sometimes, but they're not usually super helpful. I know sometimes people will send IL-6 levels too, but I think it's the first thing I'd want to do is look for kind of the other causes on our list.
I think that's great, but I think in the countries where TB is endemic, they would definitely think about starting the empiric treatment for this patient if it's a TB endemic country. But talking about US, maybe they'll think about that. Yeah, that's what I'm thinking. But
yeah, I would definitely be having a conversation with infectious disease, what's the best way to evaluate for TB, and then B, do we need to start empiric treatment while we're but I think we're kind of running short on time. So let's hear about kind of what was done.
Okay, so coming to the final aliquot, this patient had an ACE level. It was elevated. It was at 206. And they proceeded with a liver biopsy. And that was negative for any fungal or acid-fast organisms. There was also no evidence of fibrosis, but it did show numerous non-necrotizing granulomas. Which brings us to a diagnosis of sarcoidosis with pulmonary and extrapulmonary features. Having said that, I would like to share some of the teaching points from this case. First of all, extrapulmonary organ involvement is actually more common than we think in sarcoidosis. It could present in up to half the patients with sarcoidosis. When we're thinking about calcium and vitamin D metabolism in this particular disease, hypercalciuria is seen more commonly than hypercalcemia, also in up to 50% of the patients. when we're assessing a case of sarcoidosis, some of the features that we need to, pay close attention to is, for example, on physical exam, certain specific skin conditions like lupus pernio, erythema nodosum. Also, looking for eye involvement because they can be complicated with things like uveitis. On imaging, we're typically more oriented with bilateral hilar adenopathy, but there are numerous other things that can be seen, including perilymphatic nodules. Additionally, like MRIs, PET scans, to become more valuable when we're trying to evaluate for extrapulmonary involvement. And finally, patients with sarcoidosis, even if they do not have any ocular symptoms, they should have a baseline eye examination. As I said, they can be complicated with uveitis and other serious complications that may not be apparent on physical exam. So that's the end of the fifth aliquot.
By sarcoidosis. Amazing discussion, Emil and Yaz. Do y'all have any reflections on the case?
Yes, I think thank you, first of all, for bringing such an amazing case. And I believe I'm honored to be discussing it. I think it explains everything. I think the bilateral nephrolithiasis was then ultimately calcium, which was being excreted outside in the form of hypercalciuria, as we are saying that it is the most common manifestation of sarcoidosis, more than hypercalcemia. And the miliary nodules, everything, I think it explains. So most likely the right-sided pleural effusion probably could be hepatic hydrothorax. So I guess it just explains almost everything. Thank you so much for the case. Thank you.
Yeah, amplifying what Anna mentioned, this was a really humbling case. It has so many clinical data that I find it really tricky for me to go puzzling everything. I still don't know how to reconcile the high IgA or the high transglutaminase antibody, and definitely now my curiosity is sparked. I will be reading more about it. But amazing case. Thank you so much.
Yes, thank you so much to just the fabulous team from University of Rochester for presenting such a great.
Not University of Rochester, Rochester General Hospital.
I'm so sorry. Oh my gosh, I'm so sorry. Rochester General Hospital for presenting such an amazing case that I have learned so much for and so thoughtfully laid out and everything. So I definitely felt very stumped by this. So appreciate the great opportunity to learn from this.
That really was truly an amazing discussion and a great presentation from everyone. This was even more educational than I thought it was going to be. I'm going to turn it over to Deborah to kind of start the Q&A session.
Thank you so much for this great case, and thank you, girls, for the discussion. Yeah, now we want to have a few minutes to make some questions about the program. I could start with Laura, if you want to tell us about your experience, how it has been so far for you.
Of course. I always say that I'm very biased to talk about my program. So who knows me from like Instagram or other sources, platforms, I always say that I truly love my program and the environment that they have. I think my favorite part of RGH is that you feel that you're home, even though you can be far from home. You feel that you have a family and friends that support you on the way. And I think they have a very solid medical education, and they will support you to like achieve your dreams, whichever your dream is. So you are assigned to mentors from the day one of residency. You will always have someone, to inspire you and motivate you to pursue your dreams. And we have a very successful rates of match, and even Anas is here to share his story as well, soon to be cardiologist. But I feel that once you are in a place that you feel like home and that you feel that everybody wants the like your best and want you to see succeed, there's no better place to learn than this place, and for you to be excited to help each other, and you just have fun along the way. So it doesn't feel, I know that intern year I might not have this in mind, that it doesn't feel like work. It felt like work, but I was having fun along the way. And I feel that this is what I love the most about my program.
Thank you so much for sharing. If any other resident want to share too?
I guess I second Lara. Residency is tough everywhere, especially the intern year with like sudden transition, and especially with so many of us traveling like across the seven seas and settle in a new place. So I think the important thing is having very supportive seniors, supportive attendings, and the program office, which is something that Rochester General makes sure there is. The attendings, the program office, the seniors have been so supportive and makes you feel like home. Like they literally nurture all the interns and like just be there for them, which has been great so far. Yeah.
I want
It seems
to just compliment something about Dua said. Like they make sure that like we are okay. Like they literally check, are we eating okay? Are we having enough sleep? Like this type of things. And they are very open to feedback as well. We have like open access to the program coordination, like the PD so accessible to us, the APDs, the chief residents. So it's truly a community. And so you won't feel alone. You will have fun, and you will have a lot of support from your seniors, and you're gonna learn a lot.
there's a question in the chat. So for the interns, I would love to know how the transition from medical school to intern year.
I can go ahead with that. So I didn't have any clinical experience before coming to here, so definitely the transition was very difficult. On personal basis, I have never lived like outside like anywhere. I have always lived in a same city. My medical school was in the same city. Lived with my parents, so I think it was just totally challenging to get accustomed to the new system, to the new people, to the new language, as well as I was learning to live alone, like cook for the first time, made breakfast for the first time. So I think all of that was difficult in the start, but of course, like it's just how you learn. It's just the way of life, and it has to be like that. Eventually, got used to of it. Things got better. Secondly, the initial months, I would say, with Epic and everything was very difficult. I was still used to of doing everything on the papers like back home. So getting used to of that was difficult, but then again, I think it's a journey and it takes time to learn. It did not come in a day or in a week or in 2 months. I'm still learning, still struggling, but then again, as I said, the program office, the seniors, they're always there. There's a lot of support, a lot of help, and I like sometimes I end up asking same question about the Epic 5 times, but I don't see anybody annoyed, and they make sure that they answer it 5 times and show me all over again where to click and what to do. So I guess yes, with a lot of support, I think it gets easy. Does Tolu has anything else to share?
Yeah, I agree with everything you said. For me too, I didn't have any clinical experience coming into residency. And what really helped a lot was the supportive seniors and also the attending. And eventually I was able to adjust, even though I'm still adjusting and I also came late. But yeah, it's been a steep learning curve, and the program, the way it's set up for you to eventually get to the level where you feel confident and competent in clinical practice.
Yeah. One thing I would like to add here is that it was a surprise when I came in that we have this 6 weeks of boot camp. And like when I talked to the rest of my friends doing residency and other programs in the USA, they were actually just thrown in it. We had like a 6 week of boot camp where we were just, given exposure to the floors, to the clinic, to the ICU overnights. And in those 6 weeks, we were literally spoon fed. Like we had seniors all the time. They were looking into us, making sure that we are good. Like even if somebody would see me stressed, they'll be like, hey, are you okay? You can take a rest. If you want to sit, it's fine. So I mean, just knowing that there are people you can always who always have your back, and you can go back to if need be, gives you a lot of peace and a lot of satisfaction that okay, in case anything goes wrong, I have people to go back to. And that boot camp, I think, is like the best part of the program because it makes the transition much easier. Yeah, I guess that's about it.
I actually want to ask a question. This is for Anas. How do the chiefs, so first of all, do you guys have fourth year chiefs or third year chiefs? And how do the chiefs, what kind of roles do you guys have to support your residents? And how do you guys do that?
Yeah, sounds good. Thank you all. First of all, I really enjoyed the discussion of the case, and thank you guys also for bringing this case. It was an interesting one. Now, regarding, I cannot compliment the program, but to be honest, yes, it's an unbiased opinion, but I really enjoyed my time here as a resident. The program office supported me a lot to achieve my my dreams and my goals. Thankfully, I managed at Houston Methodist for cardiovascular disease, which is a great program too. I received a huge support from Dr. Jadav in order to get to that point. We got like strong attendings who supported us all the way to get like strong letters of recommendations, great clinical experience and exposure. Even when I did my away elective, I felt like my clinical experience and knowledge was solid and strong. Now, in terms of us as chiefs, I feel like our main priority, and that's also what our program director told us, is that you have to be as close to the residents as possible. Try to be as supportive as possible. Try to respond to them nicely. Try to get their requests. Try to address them immediately. I think, like from the leaders, we've been instructed to make sure that our residents are comfortable and happy, and I think that's what make us all as chiefs look forward to make sure that our residents are doing well.
Amazing. And I just want to share with everyone that's just been saying is that I'm still relatively new with the resident team, at least like this past summer. And one of the reasons that I came from my previous institution to Rochester General is the diversity. And I'm just, don't take my words for it. Like, look at the residents today. There's one from every part of the world, and if you look at their class, it's the exact same. There's people from everywhere parts of the world, and I think that diversity is something that really meant a lot to me, because I have a pretty unique background, and I feel like it really strengthens the program because you get to learn more about those individuals and their culture, and how you even apply that to patient care is actually really impressive too. So I just wanted to add that.
Thank you, Jess, for adding that. I think we can talk about Rochester if anyone want to share something about the city, how is she living there, besides that it's cold now.
I can take that one. So Rochester, when you first come here, I think the first thing that you kind of notice around October time is how beautiful the trees start looking, the colors. It's really something I've never seen before. You have so many parks to go to, so many lakes to visit around, a lot of outdoor activities to be done. It gets a little bit tricky during winter time, but even then, I think like last night I saw there's like a winter festival going on. So there's like, I believe like some skating there. So I think there's always something fun to do. And it kind of like aligns with your residency time as well, where you need to be outdoors, do more activities. So I think it's pretty great.
Jess, do you want to share, or Lara?
No, I was actually going to say that I'm starting to explore the city more now as a second-year resident, to be honest, because my hobby as an intern was to sleep. And I feel really bad because whatever free time I had available, I would just sleep. So I'm kind of enjoying a little more now. But it's a very low-cost city to live compared to New York City, since we are in New York State. Yes, it's actually sleeping is the best hobby. And I'm still in transition of losing that hobby to find a new one. but yeah, it's whoever likes outdoor activities, this is definitely the right place to come. There's so many like lakes around, the small lakes, the Finger Lakes are here. There's a lot of hiking, which I'm still very deconditioned from intern year, and I struggle like to take the stairs of Dr. Bajwa. So hiking is still not on the table. But it's such an amazing place because I feel that Rochester is, you have everything that a big city you need to have, but also Deborah is like laughing. Yes, Deborah, I get wheezy when I take the stairs of Dr. Padro. So it's like a big city, but you don't have traffic at all. It's a small city, but you have everything that a big city can offer you. And I feel that winter, and although like as a Brazilian coming from tropical country, this is like a big change, although I do love winter. But they do a very nice job in terms of snow here, because people always ask like on the interview program day, like how is to drive on the snow and all those things. But the city here, they're so organized, like they remove the snow from the roads and all that. I'm distracted with the chat now, but that's it. Like Rochester is an amazing place to live.
And I guess I would, being in Rochester since 2019, I think, so being from Toronto, Canada, I feel like I really enjoy diversity and like good food scenes. And I was very impressed for like Rochester is a small city, that's just a fact. But like for the size of the city, there's so many great restaurants. And like there's some like great like nearby cities that you can drive to if you want like a big city feel. But being an outdoorsy individual, I feel like you checked all the boxes. And it's like I wouldn't have stayed here if I felt like I couldn't build a life here. So I think for me, it was checked all the boxes. The healthcare, we're really fortunate. I think both Rochester General or Rochester Regional Health and U of R, they're great healthcare institutions. So the patients, to be honest, luck out the most. And I feel like if you want to work in healthcare, Rochester is a great place to be. And that's actually true. When we're going up the stairs, I ask questions as we're going up the stairs, and a resident wrote in my MedHub eval that I was willing to take the stairs just so I can hear what Dr. Basha is going to teach me about. So that is a fact, AMK. That actually has happened.
Awesome.
That's funny. I think we got to the end of our section. I really want to say thank you all for being with us, like presenting this amazing case and answering our questions. It was a pleasure to receive you all, and it was a really great session. Thank you much. Thank you so much, the girls, for the discussion. AMK, Yas, and Amol. It was awesome, and yeah. We hope to have you all back. Please feel welcome to present more cases. We would love. So bye-bye. Have a great rest of your day.